kidney capsule. And again, we divide this into two, T2A, 7 to 10 centimeters, and T2B, greater than 10 centimeters in size. T3 is could be any one of three types: T3A, T3B, or T3C. T3 is either tumor into the gyrotous fat and fascia outside the true capsule of the kidney, or infiltration into the renal vein. That is T3A. T3B is infiltration into the IVC below the diaphragm, and T3C into the IVC above the diaphragm. T4, of course, is when tumor has grown beyond gyrotous fascia and is grown into any of the adjacent organs, such as the adrenal gland or the colon or whatever other organ it chooses to infiltrate into. The N and M stages are quite simple. It's either present or not present when it comes to renal cell carcinoma. So treatment, surgical resection remains the gold standard even in 2021 for non-metastatic disease, T1, T2, T3, and even T4 disease. Although I will admit that it is relatively unusual to find T4 disease without other metastases. So in 2021, we would consider partial nephrectomy for T1 tumors, even in the presence of a normal contralateral kidney, and that partial nephrectomy can be done in either by open or laparoscopic or robotic means. The benefit, of course, of partial nephrectomy is a preservation of the normal kidney, and of course, it's been shown in multiple studies that partial nephrectomy in well-selected T1 tumors is as effective as total nephrectomy. That is, the oncological effect is as good, with preservation of renal function, which in turn leads to improved quality of life and probably improved length of life, because these patients who have a partial nephrectomy have a much lower risk of ending up with a reduced eGFR and chronic renal disease. Cytoreductive nephrectomy can be done in selected cases, and we will discuss this a little later. And metastasectomy, either for asynchronous or metachronous disease, can also be considered. I can't actually see current. I can't actually see my. Sorry, just a second. Currently, and this is important, there isn't any rule for adjuvant therapy in renal cell carcinoma. That is, there isn't a rule for doing a nephrectomy. And even if you deem the patient as high risk, either because it's a locally advanced tumor or a high-grade tumor, currently there isn't any proven rule for adding any kind of adjuvant medication or chemotherapy or immunotherapy-based treatment to nephrectomy. So these days, we would just still do a nephrectomy for localized disease and follow the patient up carefully according to well-established protocols. So, onto the kind of our topic, advanced cancer, cytoreductive nephrectomy, or the removal of a renal primary in the presence of metastases. Why and when? First of all, let's go back to the why. There are still anecdotal instances in the literature where a cytoreductive nephrectomy has led to an arrest of metastases. The incidence is less than 2%, but it, of course, that particular phenomenon has gained great mythical status, and I have been a consultant for just under 20 years, and I think I have seen one true case, so it is quite rare, but it's still that holy grail where it can happen, where a nephrectomy can suddenly arrest metastases elsewhere, but that's not mainstream, okay? The role remains unclear. However, certain recent studies, especially this one, the so-called Carmina trial in 2018, has really shifted the landscape with regards to cytoreductive nephrectomy. In this Carmina trial, they compared in patients with metastatic disease, they compared sunitinib alone and sunitinib plus nephrectomy. And it was designed to show whether or not sunitinib was inferior to nephrectomy plus sunitinib. And in this study, this landmark study, it was quite clear that sunitinib alone was not inferior to nephrectomy plus sunitinib. Therefore, a lot of the patients, especially with intermediate and poor risk status, since 2018, we are a lot less likely to perform a nephrectomy for those patients. We would typically just do a biopsy to hopefully define the precise histology, and hopefully, if the patient is got clear cell histology, then they can go straight on to treatment. Bear in mind, if you do a nephrectomy in intermediate and poor risk patients, and again, we will talk about those risk stratifications in a minute, then they're not benefiting from it. Furthermore, doing it means you have to wait 2 to 3 months for the patient's wound to heal before they can start any adjuvant therapy. So they lose precious time. So this Carmina study was very, very helpful in reducing the rates of cytoreductive nephrectomy in general. And we would now only do a cytoreductive nephrectomy in a patient with a good risk, which I'll be talking about in a minute. So systemic treatment. This, of course, which we're going to be talking about now, becomes the norm or the standard once disease is advanced or metastatic. As I said earlier, no therapeutic agent has yet been shown to be of any evidence in the adjuvant setting. Given a historical perspective, up until 12 to 15 years ago, there were only really 2 players on the market, that is interleukin-2 and interferon alpha. They were the treatments that were available and the treatments that were used. High dose interleukin-2, again, this is just one series that shows the kind of things that could be expected in the interleukin era. So in this, for example, in this particular series, a randomized series of non-randomized series of 255 patients, 12, that is 5% of patients experience complete response. Again, that's that holy grail of complete response where the disease is arrested, whereas only 9% of the patients had partial response. The problem with IL-2 is that it is expensive. The problem with IL-2 is that it has a severe toxicity profile associated with such treatments, such as the capillary leak syndrome, hypotension, fever, arrhythmias, and of course, mortality. Today, and in the last 10 years or so, IL-2 has largely been replaced by the more modern contemporary treatments we'll be discussing later. The second treatment, historical, that was used was interferon alpha. Now, mostly of historical value and is more or less not being used at all in the last decade. But note, up until 12 years ago or so, it was considered the standard of care in patients with metastatic renal cell carcinoma because of its ability to induce tumor regression. However, its cost and its toxicity has once again, and of course, the comparative superiority of the agents we're going to go on to discuss has rendered this now only of historical value. Now, this slide is very important. Now, in contemporary systemic treatment, the oncologic specialists have developed 2 prognostic criteria systems. And these criteria, one is the MSKCC, Memorial Sloan Kettering Cancer Center, and the other is the IMDC. And I'm just going to briefly talk about both of them. The MSKCC was the first one, and it helped to categorize patients into how they would do. These data were taken from before 15 years ago, before we had these newer treatments we're going to be discussing in a minute. And patients with patients with no factors, none of these negative factors, low canosophy, high LDH, anemia, high calcium, time of diagnosis, less than a year. If you didn't have any of those factors, then patients, even in that era, would live as long as 30 months. If you had two of these, they only lived for 14 months. If you had more than two, those patients only lived for 5 months. So there is a dramatic difference between so-called favorable risk and intermediate or poor risk patients. And that is how and why this scoring system has become so important in risk stratification and choosing treatments in 2021 and in the last decade. Perhaps the more contemporary scoring system, the IMDC, or International Metastatic Renal Cell Carcinoma Database. The IMDC is somewhat similar to the MSKCC, but contains two additional features: thrombocytosis and leukocytosis as negative factors, and does not include lactic dehydrogenase as a negative factor. The important thing is this third bullet point in this slide. For both scoring systems, a score of 0, if you don't have any of those features, puts you into the good risk category. And as I said, the life expectancy for patients with good risk criteria could be as up to between 20 and 43 months. Whereas if you had even only just one or two of these factors, that immediately put the patient into the intermediate risk, where the life expectancy was 10 to 22 months. And then, of course, if any patient had more than two of these factors, it puts them into a poor risk category, where the life expectancy was no more than 4 to 8 months, depending on the database used. In 2021, the IMDC has mostly superseded the MSKCC in routine clinical use. The important thing is to emphasize that the IMDC is used actively in 2021 to select patients for what type of treatment they're going to have. So in 2021, or shall I say in the last 5 years, the first line treatment, the group of medications that has come to the fore are the so-called anti-angiogenic vascular endothelial growth factor, or VEGF pathway inhibitors. VEGF, or vascular endothelial growth factor, binds to its receptors inducing vascular growth, that is angiogenesis. These treatments also, as I said earlier, inhibit, for example, platelet-derived growth factor. But as a general rule, they are called VEGF inhibitors as a class. Now, there are two types of targeted therapy that can work through this pathway. One is blocking of the receptor, of the VEGF receptor, and using agents, which are the commonest agents still being used, the so-called small molecule tyrosine kinase inhibitors, such as sunitinib and pazopanib. And then also, it's possible, monoclonal antibodies have been developed to block VEGF by receptors by binding to it, such as bevacizumab. Now, in the first-line treatment, tyrosine kinase inhibitors in the last decade have really come to the fore. And in this respect, the best and most studied ones are sunitinib and pazopanib, and they have shown a similar efficacy in the first-line setting. Either agent is recommended as initial therapy for untreated patients who are presented with either unresectable or post-nephrectomy for cytoreductive nephrectomy, that is, and have metastatic RCC. The most common side effects of the tyrosine kinase inhibitors is diarrhea, hypertension, fatigue, and the so-called hand and foot syndrome, which I will again elaborate on a little later. So the most recognized one worldwide is sunitinib. The trade name is Sutent, and I'm aware that this drug is available in Nigeria, although I have tried to get some information about the cost in the last 24 hours without any luck. Now, sunitinib exerts most of its clinical effects by blocking the VEGF tyrosine kinase, also the tyrosine kinase for platelet-derived growth factor, and also the c-KIT oncogene. But as I said, as a class effect, it is recognized as first in class as a VEGF inhibitor. So this original landmark study from Memorial Sloan Kettering by Motzer et al. Compared sunitinib to the, at that time, standard of care, which was interferon alpha. And as you can see from this slide, treatment with sunitinib resulted in a longer overall survival at 26 months versus 21 months for interferon alpha. And of course, critically and importantly, the patient's quality of life was a lot better on the sunitinib in comparison to interferon alpha. Pazopanib is in the same space as sunitinib, and indeed, this trial that compared both of them, they concluded that they both had similar effects. However, the patients on pazopanib seem to have slightly better quality of life in comparison to sunitinib. So TKI side effects, as I said, these are the commonest drug in this group of patients with advanced renal cell carcinoma, and therefore it is important to be aware of the side effects. And the side effect can be divided into two: the so-called on-target side effects, that is where the effect is directed towards an organ, hypertension, hypothyroidism, the so-called hand-foot syndrome, and proteinuria, and the so-called off-target side effects, where the medication causes harm in other areas. Wound healing complications is an important one. As I said earlier, any patient who has a nephrectomy, you'd have to then wait a good while, 6 to 8 weeks, I think, at the very least, to ensure that the wound is well healed before you can start them on any additional therapy after cytoreductive nephrectomy. It can also cause left ventricular dysfunction, cardiac abnormalities, spontaneous hemorrhage, usually GI, mucositis, and diarrhea. A little bit more about this so-called hand-foot syndrome. It consists of redness, swelling, tingling, and burning in the hands and the feet. And it's caused, actually, funny enough, by many cancer therapies, but of course, in this context, we're discussing TKIs. It often occurs early in the treatment course and often requires early intervention. And as you can see here, this is why as I will explain later, why this multidisciplinary approach becomes so important. These patients need a lot of support from nursing and allied healthcare, quite apart from the doctor or the oncologist. But here, simple prevention: cooling the hands and feet, avoiding any toxic soaps or soaps that irritate, using creams, loose-fitting clothes, all aiding to try to ameliorate some of this symptom. And as you can see here, treatment includes reducing the dose or altering the schedule of treatment, or even sometimes temporarily discontinuing treatment to allow healing of these lesions. Topical anti-inflammatories, including topical corticosteroids, have also been used to manage this problem. This is probably one of the commoner side effects of TKIs. As I said earlier, the VEGF receptor you can block it as a direct blocker from the TKIs, or it can also be blocked by an antibody to the receptor to block the effect. And bevacizumab is probably the commonest in that respect. And I'm only mentioning it here. It hasn't necessarily gained widespread acceptance because of the cost, and indeed because the side effect profile and accessibility profile means that sunitinib and pazopanib still remain the preferred agents in the first line. However, it was pertinent to point out that these two trials, in confirmed that in comparison to interferon alpha, again, the previous standard of care, that bevacizumab showed evidence of increased overall survival and increased progression-free survival in comparison to interferon alpha. On to another class of drugs, the so-called mTOR inhibitors. mTOR stands for mammalian target of rapamycin. Now, the two main drugs in the renal cancer space is temsirolimus, which is an intravenous agent, and everolimus, which is an oral agent that have shown efficacy in advanced renal cell carcinoma. Now, how does it work? It is a downstream effector of the, mTOR in its usual, normal, natural space is a downstream effector of the mTOR pathway and has a potential to inhibit cell growth and survival at different levels. The mTOR inhibitors therefore interfere with the synthesis of proteins that regulate proliferation, growth, and survival of tumor cells. And temsirolimus is probably the best known of these, which has been evaluated as first line, whereas everolimus is more has established itself better in the second line space. IV temsirolimus has been studied as first line therapy in patients with poor risk advanced disease. And this is important because as you will see later, Sutent works best for patients with favorable risk, whereas it became more and more apparent over the last decade that Sutent wasn't working well for patients with unfavorable risk, that is with intermediate and poor risk patients. So for example, this particular study showed that temsirolimus alone again performed better in comparison to the old standard, that is interferon alpha, with improved median survival times. Now, if you can see from that last line, the survival times for these poor risk patients were very modest indeed. However, temsirolimus gave these patients up to 11 months of overall survival in comparison to 7.3 or 8.4 with either combination therapy or interferon alpha alone. So it showed its mettle, and it certainly outperformed interferon alpha. However, like all these other drugs we are discussing today, it's got its own side effects that include hypersensitivity, pneumonitis, nausea, anorexia, hyperglycemia, and anemia. And bear in mind, these patients are already in poor state anyway, and here we are giving them medications that cause all these side effects. And I'm saying these side effects can be as high as between 10 and 20%. So they're not rare. It's not rare like maybe commoner drugs or antibiotics, where most of the drug risk with common antibiotics we use, for example, are in the order of 5% or less. Most of these side effects in this space for these medications are typically in the order of between 5 and 20%, which I think is important. Now, to summarize that segment, the drugs that have been shown to be effective in first-line therapy and that has held its place, if you like, is sunitinib and pazopanib. Now, following first-line therapies, the patients in 2021 are typically given second-line treatments, and these are the current second-line treatments that have been evaluated, which we will discuss briefly. These include tyrosine kinase inhibitors such as axitinib, cabozantinib, and sorafenib, and also the orally acting mTOR inhibitor, everolimus. Axitinib is a highly potent and specific TKI that inhibits VEGF receptor 1, 2, and 3. And in this particular study, one of the landmark studies, and remember, these are patients who have had prior treatment with sunitinib or pazopanib, that is in second-line treatment. The axitinib in this study was shown to improve progression-free survival to 6 months in comparison to 4.7 months with sorafenib in this particular study. Now, these are modest, and I always marvel at oncologists who are doing this work over many years, because often they gain here, they gain there, they gain 1 or 2 months, 3 months in this study, then about 2 or 3 years, they gain another 3 or 4 months. And this is how the oncologists, which I think they ought to be complimented, have been bashing away at this particular disease for the last 10 to 15 years. So here we are, median progression-free survival, which was the primary endpoint in this particular study, was improved to 6.7 months as compared to 4.7 months. These are, of course, with the attendant risks with regards to quality of life of these patients, but there has been a slow but definite improvement. And patients in 2021 can get second-line therapies and even third-line therapies. With regards to everolimus, which has also been evaluated in the second-line space, the good thing about this is patients can take everolimus at home, which itself is welcome for patients. And in this particular study, again, one of the landmark, there are hundreds of studies in this space. One of the landmark studies that compared, that treated patients after they had progressed on sunitinib. Again, see very modest progression-free survival of 4 months for everolimus in comparison to 1.9 months for placebo. The toxicity of everolimus was similar to temsirolimus. I think it's pertinent to point that although everolimus has shown clinical efficacy and become an option for patients who have progressed on previous therapy, newer treatments such as cabozantinib and nivolumab, which are reviewed below, have since shown better survival improvements when compared to everolimus and are now, in 2021 at least, preferred options. But it had its space, it had its day, it had its time. Now, cabozantinib is a newer generation TKI and has also established its place as second-line treatment. And you can see from this study that in patients who had been treated previously with a previous agent, usually sunitinib, progression-free survival was longer with cabozantinib at 7.4 months versus 3.8 months with everolimus. So this study compared cabozantinib versus everolimus, which is why, as I said a slide ago, that cabozantinib has been shown to outperform everolimus in a second-line treatment. On to the last sort of group of medications, the newest one, and in a sense the most interesting of the group, the so-called immune checkpoint inhibitors. There's a lot of research underway in not just kidney cancer, but multiple cancers, prostate cancer, bowel cancer, melanoma. These immune checkpoint inhibitors, even for benign disease, such as colitis, are appearing all over the place in medical treatment, both cancer and non-cancer. Specifically, the immune checkpoint inhibitors targets the programmed cell death pathway. That is, normal organs that are functioning properly have a programmed cell death pathway with a programmed cell death receptor and its ligand. And it's been shown that PD-L1 expression has been shown to be one of the ways that kidney cancer cells escape immune recognition. And how these drugs work is that they block the PD cell pathway that the kidney cancer cells use to avoid immune recognition, and allows the body's own cytotoxic T cells to recognize the cancer cells. So these T cells have been masked. Sorry, the cancer cells have been masked by the substances produced by the cancer. And when you use these immune checkpoint inhibitors, it allows the body's own cytotoxic T lymphocytes almost to recognize these cancer cells for the first time and therefore cause cell death of the cancer cells. So that is the principle that these immune checkpoint inhibitors work. I'm not necessarily going to spend too much on it other than to again explain the principle of these newer drugs. The three drugs for kidney cancer are nivolumab, pembrolizumab, and ipilimumab. These latest group of drugs, the immune checkpoint inhibitors, again have really significant, and as you can see from my headline here, severe and potentially fatal immunological adverse events. And the risk of this is between 10 and 20%. No, I mean the risk of the side effects, not the risk of fatality. They include rash, diarrhea, fatigue, and in the second half, the bottom 2/3, all of these are immune related. So the same mechanism that is allowing the kidney, the body's own T cell lymphocytes to recognize the cancer is unfortunately causing the same cytotoxic T cells to attack and cause autoimmune issues. So all of these issues are autoimmune. It's the body attacking itself. Diabetes caused by autoimmune destruction of the insulin-producing cells in the pancreas. Hepatitis in the autoimmune hepatitis. Myocarditis, autoimmune myocarditis. Nephritis, autoimmune myocarditis. Which is why I say in this headline that a lot of these side effects, if and when they occur, they are commonly treated with steroids. Unfortunately, even though these patients can sometimes be managed with high-dose steroids, it does not appear to negatively affect the cancer controlling properties of these medications. So the most recent advances, and I'm talking about 2018 to now, are that the previous first-line treatments such as sunitinib and pazopanib have now been overtaken by combination therapies. So, for example, in the first of these three studies, which I'm not necessarily going to in detail, nivolumab plus ipilimumab versus sunitinib in advanced renal carcinoma in 2018, the main conclusion is that overall survival and objective response rates were significantly higher with nivolumab plus ipilimumab than with sunitinib alone among intermediate and poor risk patients with previously untreated renal cell carcinoma. So what I'm trying to explain is in 2020, between 2018 and 2021, these new combinations have now superseded sunitinib and pazopanib in the first line space. And in this slide, which is very, very recent, in 2019, the ESMO guidelines for kidney cancer now puts axitinib plus pembrolizumab as the recommended agents in favorable risk patients. Remember the IMDC risk strata we discussed earlier, and favors axitinib or pembro or ipilimumab plus nivolumab in intermediate and poor risk patients. And this last, I'm coming to this last first slide, is a slide from 2021, the National Comprehensive Cancer Network of the United States. Again, you can see the most recent preferred first-line treatments in the red or brown first line: axitinib plus pembro or pazopanib or sunitinib, ipilimumab plus nivolumab, axitinib plus pembrolizumab or cabozantinib. These are the preferred regimens in 2021 in favorable and intermediate risk patients. Now, all of these patients will still be eligible for second line and even third line treatments when the initial treatments have ceased to work. But what is critical to recognize is that up to 30% of patients are now having the progression-free survival in these newer treatments in the top line, this top third on this slide. They are now, the patient can now, 30% of patients can now expect to have a 30-month 2.5 years of progression-free survival. And that is a big leap from where we were 10 or 15 years ago. Now, I fully accept and realize that costs are still an issue in Nigeria, but here we are just trying to present what is contemporary, what is the standard of care in 2021. So, in conclusion, I hope I've demonstrated that this is a very rapidly developing field. My intention was to hopefully get you all to understand the principles and indications for treatment of advanced renal cell carcinoma. I hope I have shown that these are complex medications with complex efficacy profiles and side effect profiles. It is not the case as well that patients who have advanced disease must have treatment. There are also important decisions about timing to treatment, timing of starting treatment. There are important decisions to be made about dose modification, about stopping and starting medications, about deferring treatments, about maybe giving patients steroids for managing some of those immune checkpoint immediate side effects. So I want to place a great emphasis on training and team rather than the idea that anyone can be prescribing or using these treatments. In any good cancer center, patients must have rapid access. And you can see some of those side effects are quite terrifying. Patients must have 24-hour access to the treating center. And this is where nursing support comes to the fore. But the area is rapidly changing, is rapidly developing, and patients with advanced kidney cancer are surviving longer than ever before. Thank you very much for your attention. So just gonna
thank you very much, Banji, for such an eloquent talk about renal cancer. I'm now thinking, why did I become a urologist instead of a proctologist? But there we are. So what do you want to do now? Do you want them to present the...
So I want them to hold on to the questions if there are any, but I thought that it would be nice for the residents who send those slides in to present that case report. I think it's worthy of discussion, and let's use hopefully what we've learned to apply to this particular case.
Okay, so that's
that case.
That's Kayode Abayomi.
I mean, I've got the slides.
Yeah, Kayode Abayomi.
If you're not prepared, I've got the slides of your own case.
Yeah, hello.
Hello, okay.
Yeah. Hello.
Hello, do you have your slides? Do you want to present your case and have a discussion about it? Oh, I don't know what Banji said.
Yes.
If you have I'm online.
Hello,
Okay, all right. If you give me a minute.
And by the way, thank you very much to Dr. Sharif Ogunlayi, who's just given me some pertinent information. He's kindly texted me and let me know that 1 month of sunitinib, Sutent, costs in Nigeria 350,000 naira, and that's in the last month. That's very current information in the last month.
Okay, and does anybody have an idea how much it would cost to us? Kayode is sharing his screen now.
So sharing. Okay, sorry, I'm having a little challenge sharing my screen.
Yes, I can see you're having a challenge. I mean, I can show the slides. I have looked at them and I can just briefly talk through them. Shall I?
Okay, yeah, that's fine. Thank you.
Okay, thank you. So this is the case you kindly presented. I'll just go through it briefly and then maybe come back to talk about the pertinent points, just for the house really. 34-year-old housewife, intermittent total painless hematuria associated with passage of clots for 1 year, left flank swelling, progressive low back pain with inability to bear weight on the lower limb. She doesn't smoke, not hypertensive, no family history. On examination, a young woman, she wasn't pale, she's actually not anemic. Observations were fine, large left loin mass, palpable, but critically, power was 0 in all muscle groups of the lower limb with a sensitive level of T2. I think that's very important. Inner sphincteric tone was normal at the time, and her imaging showed a large renal cell carcinoma with metastasis to the spine. So this is a chest X-ray which was clear. Parameters were actually normal, apart from slight renal dysfunction. She wasn't anemic. Her white cell count, I believe, is normal, and her platelet count is normal. So patient has had a cytoreductive nephrectomy. Note she had multiple aortic lymph nodes and tumor infiltration of the left psoas muscle. One thing which we don't know is the histology. Do we know the histology yet? Is it clear cell? Of course, we would talk as if we hope it's clear cell because that's the only one where there is any meaningful discussion, as I've explained. Was it clear cell carcinoma?
So it turned out to be papillary cell carcinoma.
That's very interesting. I was thinking that it would be earlier, just from the appearances on the CT scan. I thought it might be papillary. Now, interestingly, papillary has, in general, of course, this lady unfortunately has metastasis already. Papillary renal cell carcinoma has, in general, slightly better prognosis than clear cell renal cell carcinoma. But that difference in prognosis really, and strictly speaking, is in relation to T1, T2, T3 non-metastatic disease. That is, stage for stage, if you did a nephrectomy on a patient with clear cell carcinoma or a patient with papillary cell carcinoma, there's about a 10 to 20% better prognosis with papillary renal cell carcinoma in comparison to clear cell renal carcinoma. However, in this particular lady, she has metastatic disease, so that prognosis advantage is of no consequence. And indeed, she's in this particular situation, she's in a far poorer state because none of the treatments we've discussed are shown to work. Now, let me be clear. They can be used, but the efficacy, the response rates have been shown to be relatively poor. But if I may flip this discussion on its head and say, what if she was clear cell renal cell carcinoma? What if she was clear cell renal cell carcinoma? The question is, should we have performed a cytoreductive nephrectomy? Well, she was 34, she wasn't anemic. However, you can see that she's not favorable risk. Why? For the simple reason that her Karnofsky performance status was probably about 40 or 50, not over 80. Therefore, she has at least one factor that places her into the intermediate risk regime. And therefore, as the Carmina study indicated, there is little benefit in nephrectomy alone in comparison to sunitinib, if you remember from earlier on. However, I don't want to cast any aspersion on the decision making here. There are other reasons why this lady might have had a nephrectomy. She may have been in pain, and it was not clear whether the pain was from her spinal metastasis or from the sheer bulk of this left kidney tumor. And of course, she had been having recurrent visible hematuria for a year. There are very little interventions that will stop the hematuria. So significant and gross and ongoing recurrent hematuria and or pain from the tumor bulk are separate indications. But let's be clear, the Carmina study would suggest that at least there was no oncological benefit in doing a cytoreductive nephrectomy in this patient. However, I accept that clinical decision-making was made in the light of how she presented. So that's my own commentary about this particular case. So again, if we again advance the argument that what if she was clear cell carcinoma? Well, if she was clear cell carcinoma, and I've already suggested that she was intermediate risk, she will go on to one of those two modern treatments, such as nivolumab plus ipilimumab or axitinib plus ipilimumab would be the contemporary standard of treatment. If she was clear cell carcinoma in Nigeria, we know sunitinib is available, and I'm sure that is what would be used. And I suspect it is what will be used anyway, even though, as I've explained, we have a very poor and low expectation of any benefit. So the life expectancy of this patient would be in the order of a year, I think, or less, given what we know. So that's my own commentary on the case. I don't know whether any of you residents have any questions or comments either about this case or about the presentation, please.
Banji,
yeah,
there is a couple of questions on the chat.
Okay. Can you read them to me?
Okay.
Or, please.
From Alabi Popola, his question is: if RCC patient with intermediate or poor risk can have further treatment with immunotherapy like nivolumab and ipilimumab after nephrectomy, then can we say that there is a role for adjuvant therapy after nephrectomy?
So I don't think so. I don't think there's any evidence that so the point, let me qualify what I said earlier. Not having anything that has been confirmed to be of use with adjuvant therapy is in clinically localized disease. So of course, the treatments that we've been discussing are about patients with advanced disease. So they're not considered adjuvant therapy. They're just actually therapy. So if we get our terminology correct, it's not adjuvant therapy, it's therapy. Adjuvant therapy, as I referred to it earlier, were for patients with clinically localized disease who had had a nephrectomy. There's no evidence that giving sunitinib or giving any of these agents will reduce the relapse rate when the patient has had surgery for hopeful cure. So, and even in higher risk patients, so patients with higher grade disease or bigger and bulkier disease, if they are not metastatic, the evidence is there is no role for banging them on treatment. You would wait for them to develop measurable metastatic disease before offering them this treatment. So these treatments that we've discussed are only ever given when there is measurable advanced metastatic disease. Is that, I hope that answers that.
Okay, the second question is from, let me just see who this from Redme. I'm assuming that's a nickname. If it's not, sorry. Biopsy of renal tumor is not a mainstream practice here for various reasons. But we have started to see patients being placed on sunitinib and others with aim of tumor downgrading before possible radical nephrectomy.
Without biopsy?
Without biopsy, yes.
That doesn't make any sense to me.
Okay, and it says that then we can say there's a role for, oh good Lord, then we can say there is a role, sorry. The question just skipped up again. Let me go there. Okay, so later.
So the biopsy, I think, is so important because if it's not clear cell, then by definition, we're just, excuse the phrase, pissing in the wind.
Okay, let me
if
finish
it's
the
clear cell,
sentence.
then the patient has, sorry.
I was going to say the last part of that sentence was, where are we likely headed with this practice?
Right. So my comment on that is we would not give, and I would not advocate giving adjuvant therapy without biopsy evidence. Simple. And there are precise, which I have not discussed today, and this wasn't the place for it. There are treatment regimens for papillary, treatment regimens for chromophobe. Yeah, the results are very poor, but the point is, it's only, these treatments are only of use. That's important, yeah? 350,000 naira a month. These treatments are only of use in clear cell, and therefore the biopsy is essential, in my humble opinion.
I think.
Remember, sorry, another point, Funshaw. Remember, the biopsy is typically local anesthetic, ultrasound guided biopsy by a good interventional radiologist. It's done under a local anesthetic. The patient comes in as a day case or stays for one night for observation, and you get a result with the needle biopsy. So it's not dangerous or difficult, I think, to get a biopsy, is what I'm trying to say. So therefore, I don't understand why it's not being done. It should be being done, I think.
Yeah, I think I was just going to add to what Banji said, because while working colorectal surgery, it's not just even the type, and with colorectal surgery, most of our cancers are actually adenocarcinoma. And doesn't matter much, but the point also is that the biology of the tumor matters, and it determines what sort of treatment you're going to give, and what sort of things you're going to do. And sometimes you are what's it called, flummoxed by an outcome. So I have a patient under my care at the moment, and that we thought, oh, it came in, we thought it must be adenocarcinoma, and then somebody said no, it's pseudomyxoma, and then we did a histology, and the histology comes back as sarcoma. Okay, and that's the important part of histology, and I don't think that putting patients through cytotoxic treatment without histology is good practice. That's another, oh, sorry. Okay, well, Redmi is obviously gone on a bit. I said, thanks for the information about biopsy. Interventional radiology is just taking its root here. We hope to get there soon. Interventional radiology. And
I have said, I'm sure you, we, because I am still a we when it comes to also. And we, I mean, it's with you guys, we will get there. I mean, it's these interventional, the biopsy of a renal mass are among the simplest of it. It can probably, let me be clear, it can probably be done by any urologist or resident with a true cut going through the flank. I'm not saying that's the ideal thing, but the point is it will normally be done as ultrasound guided to make sure you're not hitting bowel or going into the chest. But for some of these larger renal masses, for example, the one that the CT scan you shared, it will be relatively straightforward to get it anatomically through the just underneath the 12th rib, going and going directly onto the tumor and getting a biopsy. Although the ideal thing is ultrasound guided. Any other questions or comments, please?
Anybody raising their hands?
And also, I'm not sure the evidence for sunitinib usefully shrinking the tumor to make it resectable is necessary. Again, from the Carmina study, I'm not sure the rationale is sound, but it's a very emotive subject, of course. Patients would like something to be done. So perhaps if people are practicing that way, I hope they will maybe one day publish the effects of that. So I don't want to be disparaging in any way, because I don't want to be pontificate in any way, because these are emotive subjects.
Okay. Another question. Is there any test that can be done genetically to know the genetic status of RCC in order to personalize treatment of RCC? Because study has shown that there are variants of clear cells tumors, variants of papillary RCC with different tumor biology, different response to immunotherapy. So are there pre-test genetic screening to determine tumor biology with a view to formulate?
So I'll be very honest. I will say that there are studies going in this space, and I will also say I'm not aware of any that has reached clinical practice, at least not while I was researching this study. But there are studies and articles being written about that kind of subject, but not, to my knowledge, has reached routine practice. So most of the agents we've discussed today are now in quote unquote routine use for the appropriate indication.
Okay. Any more? Let's see. Any more questions? Okay, I can't see any hands. Okay, just can't see any hands going on. Now, I have all your attention, and if you forgive me, keep on thinking whatever questions you have for Banji at the end of this, but give me about 3 minutes. I just want to put something across to you guys, and I'm going to share my screen now. Okay, I can assume that you all see my screen. Can you see the screen yet? Somebody answer, anybody?
Yes.
Yes, okay.
Yes, we can.
Okay, that's wonderful. I just thought I should really get back to you about feedbacks. Feedbacks are important. Sorry. Let me come back. Let me come back. Before I share the screen, there's a small poll that I want you to answer. It's all anonymous. Okay, but I give you 2 seconds to answer that. Sorry, 2 minutes to answer that. Okay, can you answer that now for me, please? Yes, okay, somebody answer. and the poll has come to an end. And what's quite surprising, that you're all online at this very moment about giving feedbacks. And a single question, is it acceptable for your consultants to refuse to give you any feedback if you have performed an important major operation for the first time? And 100% of you, of those who answered, disagree or strongly disagree. I won't go, it is not a lecture, just going to go around why I brought this up. But what is actually important was that I gave you 2 minutes to answer that. And there are, how many people online now? Yes, there are 18 of you online now, and 4 of you did not bother answering. And that is just not too bad in the sense that at least we have 14 of you who answered. Now, the reason I obviously bring that up, then I share my screen now again. Okay, so I'm sharing my screen and it's all just essentially about feedback. And I have written, okay, that on renal cancer today, it's lasted about 70 minutes, and the 20 of you who have been part of this talk. We go back to the very first one that we did, and audit and research, there were 40 of you who were on that, but only 13 of you gave feedback. That's 33%. That's about a third of you that attended gave feedback. So it's a minority response in the sense that 66% did not. So we don't know what the majority think or what the majority want. We don't know because only a minority did that. So, and this is a response that you gave for those who answered, and I'm very grateful to the 13 people who answered, but this is a response you gave, okay? I'm looking at the parts that what can be improved, any other comment, and you can see that. But what I want to show you is the difficulty you have when only minority people give feedback. Let's go to the comments that what can be improved. One person said, a quiz towards the end of the talk. That's only 8% of the 13 who gave feedback. So it's not that important, we have to assume of those who gave feedback, but more importantly, it's about less than 3% of everybody who attended. So what do we make of these things? One person says a post-lecture activity. Again, 3% of those who attended, and yes, I did put a quiz on only 8 of you answered out of 40. Interactivity is the majority where we have 3 people, and we could say that's probably significant of those who actually gave feedback, of the 13 people who gave feedback. But again, it's only 8% of everybody who attended. And then more time allotted for the session, again, 3% of those who attended. And you can see that when we look at the things that you can improve, we cannot make sense of it at all if minority of people are the only people who give feedbacks. Now, there were good feedbacks. Okay, so 13 out of 13 strongly agreed that the lecture that was given for the audience that was relevant or made their expectation. But that's not the point, because it's only 33%. It could be these are the people who liked it, and that's why they responded. Could it mean that 60% of the people who did were being nice and disagree about all of that? Now, obviously, you can say, what's this guy doing about this? I put in this topic here. It's me. I run 2 days of educational lectures every year, course every year. And I spend a whole day teaching about feedbacks because feedbacks are very important. And as you all said yourself, if you've done an operation, it helps. We shared the comments about what we can improve on the WhatsApp group of those of us teaching, and everybody thought, okay, yes, we want more interactivity. But I think that in order to make anything about it, we need to do the feedbacks. I think the 19 of you. And what I've written is, how long does it really take? It takes 5 minutes, less than 5 minutes. And if we take that Mr. Adeyoju today has spent about 70 minutes talking, and is probably sent, let's just for argument's sake, spent an hour preparing that. So I've put it roughly 150 minutes to prepare and teach. It's only 3% of the time that he has spent giving the lecture that he would take it to give feedback. Feedbacks are important for you as practitioners, for any educational purpose, and for us as lecturers and organizers for these things to know what is going. So I'm hoping that I've reached you all. I've made the feedback for this session available, and that I think from today that we can hopefully have at least about 80, 90% of you giving feedbacks. Banji, sorry, any more questions for Mr. Adeyoju? Oh God, it might be that the whole room is silent. Any more questions? Okay, Banji, any final words?
No, thank you very much. I wanted to, I suppose I call it a disclosure. So in the UK, the practice is slightly different, and I'm a surgeon, I'm a urological surgeon, and I am primarily involved with diagnosis and initial treatment. So I do a lot of nephrectomies for kidney cancer, partial nephrectomies, total nephrectomies. And when it comes to advanced disease, we, of course, arrange the biopsy because we see the patients first. But we typically, at least in the UK, we would then, and I think mostly in the US, we would then refer the patient to the oncology service, and it is them who are giving this treatment. But of course, we are still the custodians of the treatment, I think. We are still the patients, we are still the ones who are going to initially advise the patient of what treatment they're likely to get. They might want to know about side effects. They might want to know about what their life expectancy or their outlook might be. So it's still very, very important to learn about this. And I'm being very honest, you guys challenged me to do the work I did today. It's very easy to do what I need to do and refer the patients on, but your challenge to me was to update myself in this space, and it has been very useful for me. So it's been a good thing for me. So thank you for your time, and we'll see you again on another Saturday in a few weeks' time.
And finally, before you all go, just to say that the slides that Mr. Adeyoju has done will be on the site once he sent it to me. And two, I do apologize that this video did not start at the beginning. It sort of started about a sort of the way into the program. So you're going to have a truncated video. And then finally, oh, there's a question that coming of it. Finally, in one of the feedbacks that I got, somebody wrote that why can't we do something for people, I think it's plastic, I don't know, cardiac or whatever the three subspecialties are. So I'll ask Fumilayo Shoneye if you want to get in touch with the specialist people that we don't have titles for them to give, to agree to a topic they want to do, one for plastic, I think, one for, I don't know, it's cardiac, and one for neurosurgery. And I'll find out whether I can find somebody to do, and we'll probably pair it up with another lecture in one weekend. Banji, I have, okay, thanks. Okay, Banji, I have a question from Alabi Popola.
I'm actually typing a response now.
Okay.
I think a biopsy would allow better patient counseling. I mean, treating, yes, we said most of them are clear cell, but then funny enough, the example we had today wasn't clear cell. So it allows patient counseling. It allows you to know or how to explain to the patient what they might expect. And if they are not clear cell, then they are going to expect less than the evidence suggests. And I think that's part of our duty, isn't it? Is to be able to appropriately manage the expectations of our patients. So that's my answer to that question. I think it's a fair question, but I also feel, and I feel this strongly, that biopsy is not complex. It's not difficult in the right hands, and it should not be seen as a hindrance to patient management. Indeed, I can tell you this, our oncologists would not even accept our patients without a biopsy. So how about that? They wouldn't accept our patients without a biopsy.
And ditto here as well. Our oncologists won't do any treatment without biopsy. Yeah. Not at all.
And also another additional point, patients who go into clinical trials, and these clinical trials are happening all the time. I know maybe they're not happening in the setting where you are, but only patients with biopsy-proven disease can enter clinical trials. Only patients with biopsy-proven disease can have access to new treatments. And I think there are several reasons, I think, why biopsy is the counsel of perfection. So I get that maybe there are hindrances, but it wouldn't be right or fair to say it's not making a difference. It absolutely, I believe, biopsy makes a difference to how we manage the patients and their expectations and our expectations of whatever we're doing for them.
Okay. Oh, sorry. Okay, I think that's not the question. Okay, that's one. Okay. Any more? Thank you very much.
Thank you all. Have a happy weekend. Happy Saturday, as we say in Nigeria.
And happy Saturday to all of you.
Thank you.
Banji, thank you very much.
Thank you, Funso.